Welcome to this lecture on resuscitation in the neonatal intensive care unit. This comprehensive lecture based on 9th edition, presented by me, Dr. Salm Keshba, a neonatal specialist. Resuscitations occur 10 times more frequently in the NICU than in the birth setting. Only 1–2% of NICU admissions require chest compressions, and acute respiratory compromise is the leading cause of cardiac arrest. Our learning objectives for this video include describing NICU decompensation's pathophysiology and applying a systematic team-based algorithm. We will also articulate the rationale for choosing the correct resuscitation framework, recognize different types of shock and arrhythmias, select appropriate interventions, describe post-resuscitation care, and design a unit-level quality improvement plan.
NICU resuscitation differs significantly from delivery room NRP. NICU patients have completed the transition, often have chronic diseases, and established vascular access. The NICU toolkit is broader, including NRP, PALS, and POCUS. Remember, acute respiratory compromise is the #1 cause of cardiac arrest in the NICU, so address ventilation first.
Common causes of NICU decompensation are categorized as mechanical or airway, pulmonary, cardiovascular, and metabolic or CNS. Mechanical and pulmonary issues include ETT displacement or pneumothorax. Cardiovascular causes include different types of shock or tamponade. Metabolic and CNS causes include severe hyperkalemia or medication effects. Know your patient's diagnoses. They are your fastest diagnostic tool when seconds matter. Choosing between NRP and PALS depends on the event's etiology, not just age. NRP focuses on newborn resuscitation with airway first priority and a 3:1 CV ratio. PALS is for infants and children with circulation as the first priority and a 30:2 or 15:2 CV ratio. When in doubt, prioritize effective ventilation first.
Acute respiratory compromise is managed using the DOPE assessment. D is for displaced, O is for obstructed, P is for pneumothorax or effusion, and E is for equipment. Address the underlying cause in parallel with ventilation. A flat ETCO2 means no ventilation until proven otherwise. Start bag mask immediately.
The step-by-step approach starts with immediate ventilation. Run the DOPE assessment in parallel. If the heart rate is less than 100 BPM, escalate ventilation and consider re-intubation. If the heart rate is less than 60 BPM, start chest compressions and prepare medications. Secure the airway as needed and call for help early, ensuring sufficient team members are available. Ventilation considerations vary for NICU patients with chronic conditions. For BPD, use the patient's known effective settings as a baseline. For pulmonary hypoplasia, aim for a lower PIP and avoid excessive tidal volumes. Pulmonary hemorrhage requires increasing PEEP and considering intratracheal epinephrine. For congenital airway disease, document the airway plan and ensure videolaryngoscopy is available. Recognizing shock involves 3 stages: early, progressive, and decompensated. Early signs include tachycardia and decreased urine output. Progressive shock involves hypotension and metabolic acidosis. Decompensated shock presents as bradycardia and end organ failure. Bradycardia is a late sign of shock. POCUS is vital for rapidly assessing cardiac function and volume status at the bedside. Initial management for shock depends on the category. Distributive shock requires fluid boluses, blood cultures, and broad-spectrum antibiotics. Hypovolemic shock necessitates rapid volume resuscitation and stopping the source of hemorrhage. Cardiogenic shock management focuses on minimizing fluid and using inotropes. Obstructive shock due to pneumothorax requires immediate needle thoracentesis. Emergency pericardiocentesis is crucial for tamponade, and optimizing ventilation is key for PPHN. Suspect tamponade in cases of sudden decompensation with UVC or PICC in situ, P arrest, or refractory bradycardia. POCUS findings include pericardial effusion, RV diastolic collapse, and a plethoric IVC. If suspicion is high and POCUS is unavailable, proceed directly to emergency pericardiocentesis without delay. The procedure involves a brief timeout, specific equipment, and careful needle insertion sub-XI foidly. Arrhythmias are classified by rate and QRS width. Management depends on whether the infant has a perfusing pulse. For bradyarrhythmia, treat the cause. SVT may require adenosine if stable, or cardioversion if unstable. Wide QRS tachycardia requires cardiology consultation. VF or pulseless VT follows the PALS cardiac arrest algorithm. Severe hyperkalemia is the most common metabolic cause of NICU arrhythmia. Rehearse a protocol now. Hyperkalemia is a silent arrhythmia killer, progressing from peak T waves to VF or asystole as potassium levels rise. Treatment must begin immediately with membrane stabilization using calcium gluconate. This is followed by shifting potassium intracellularly using sodium bicarbonate, insulin, dextrose, and inhaled beta agonists. Treat the ECG findings, not just the lab value. Act immediately if you see peaked T waves or widened QRS in a high-risk infant. Cardioversion is synchronized to the R wave of the QRS, used for perfusing arrhythmias like SVT, and requires the defibrillator's sync mode to be ON. Defibrillation is unsynchronized, used for pulseless rhythms only, such as VF or pulseless VT, and the sync mode should be OF. Confusing these two can be fatal. Do not delay CPR for defibrillation. Vascular access choices include UVC, PICC, peripheral IV, and intraosseous access. UVC offers central and rapid drug delivery, but is only feasible for the first 1 to 2 weeks. PICC lines are for medication delivery and long-term use, but are small bore. Peripheral IVs are widely available but have poor flow during shock. Intraosseous access is the first choice for emergency access when IV is inadequate, as it is fast and delivers all medications. Do not delay ventilation or compressions to establish access. This table summarizes medications used in NICU resuscitation, focusing on indications and doses. Key drugs include epinephrine for bradycardia, normal saline or O-negative PRBCs for hypovolemia, and adenosine for stable SVT. Remember, a 10-fold epinephrine overdose causes intracranial hemorrhage, so weight-based dose cards and a pharmacist or medication nurse are essential. Resuscitation procedures must run in parallel, not sequentially. Respiratory procedures cover intubation and chest tube placement. Vascular and shock procedures include intraosseous access and pericardiocentesis. Cardiac interventions involve synchronized cardioversion or defibrillation. POCUSIS, a diagnostic tool for cardiac function, pneumothorax, and line localization. Assign a dedicated procedure team member early to minimize delays. Post-resuscitation care in the first hour is critical. For airway, confirm ETT position and optimize ventilator settings. Hemodynamics includes continuous BP monitoring and perfusion assessment. Temperature management targets strict normothermia, avoiding hyperthermia. Metabolically, target glucose between 50 and 110 mg per deciliter. Neurologic care involves AEEG/EEG and head imaging. For the family, communicate honestly and document discussions. Maintain vigilance to prevent secondary injury from hyperthermia, hypoglycemia, or seizures. Effective teamwork is crucial in NICU emergencies. Ensure a designated, hands-off team leader maintains situational awareness. Roles must be assigned early. Utilize closed-loop communication for every order. Delegate workload to avoid single-person overload. Finally, know your environment and anticipate risks, as communication failures are a major cause of preventable deaths. Debriefing immediately after a significant event is vital for quality improvement. Use a structured format, include all team members, and ensure a psychologically safe session. Key quality metrics include staff competency, medication card availability, and survival to discharge. Simulation combined with structured debriefing is the most cost-effective QI intervention. In this teaching case of a 25-week infant with sudden deterioration, the immediate problem was an unintentional extubation, indicated by a flat ETCO2. The team reacted quickly by starting bag mask ventilation, confirming the definitive intervention was ventilation, as the heart rate improved within 30 seconds. This highlights the importance of immediate, effective ventilation. Our second case involves a former 24-week infant with severe BPD and trachobronchomalacia who suddenly became bradycardic and cyanotic. The problem was thick secretions causing tube obstruction and distal airway collapse. The key insight was the respiratory therapist tailoring ventilation settings based on patient-specific BPD physiology. Remember, the algorithm doesn't solve every case. Patient-specific knowledge does. Avoid these 5 common NICU resuscitation pitfalls. 1. Using generic ventilation settings for BPD patients. 2. Delaying resuscitation while seeking IV access. 3. Missing tamponade in patients with central catheters. 4. Using small PICCs for emergency fluid boluses. 5. Confusing synchronized cardioversion with unsynchronized defibrillation. Here are 5 practical bedside pearls. Know your BPD patient's baseline ventilator settings. Treat a flat ETCO2 as a pre-arrest sign, and start ventilation immediately. Suspect tamponade in sudden collapse with a UVC or PICC. Treat hyperkalemia based on the ECG, using calcium gluconate for peaked T waves. The team leader must direct, not perform hands-on interventions. To summarize the core principles, prioritize ventilation first. Recognize that the NICU differs from the delivery room. Systematically run the DOPI assessment. Choose NRP or PALS based on etiology. Suspect tamponade with UVC/PICC and collapse. Treat hyperkalemia based on the ECG. Train for IO access. Use POCUS as a resuscitation tool. Maintain vigilance in post-resuscitation care and continuously simulate, debrief, and audit for improvement.